So let's continue with the third topic related to RCH care. In this topic we will be discussing the uh, child related components and various policies at global and local level. So if we go by the child related things, the most important thing is growth charts. So what is this growth charts? They were first developed by David Modler. So it is basically a sequential event showing it is a chart which demonstrates that with the how weight changes with age. As the age improves, how the weight of a child increases. So this way a road-like structure is created. So we say it is the road to health of a child. So the growth chart, in order to understand it, we should know what is growth. So growth, one thing is growth, one other thing is development. Growth is increasing a physical parameter, say weight increase. Our development is more to do with the quality, say, say changes in mental structures. So this is the basic definition with regard to the growth chart. At presently, more than 55 growth charts are there. However, we have to be careful. We have to be aware about WHO growth charts and the growth charts that are used in the ICDS program, Integrated Child Development Services program of India. So WHO growth charts. Initially, we used to have standards by NCHS. So NC National Center for Health Statistics growth standards were reference standards were used in order to compute it, but there were issues with it because it was primarily using the data of US children. Recently, a new study was conducted by the name MGRS. So MGRS stands for Multicentric Growth Reference Studies. So this was done by WHO in various countries between 1997 to 2003. So it is not only in USA, the sample was taken from Brazil, Ghana, India also, Norway, Oman. So uh, basically, right now, while using growth charts, we are using MGRS standards because the sample size, the diversity of children is far more. If we compare, so the first question that can come is, what would be variation in growth charts with regard to measurement of stunting, underweight or overweight when we compare NCHS and MGRHS? So if we do this, we will find that MGRS standards, the stunting, so stunting as we know is height for age. So the incidence of stunting would be more throughout the child development phase, right from the birth till 5 years of age. But if we go for wasting, it is more. It would be calculated more in case of MGRS, especially during infancy, during infant child, that is first year of the child. The wasting would be calculated more. Then third aspect is overweight. So this would also be counted more, so the prevalence would be more of overweight. And the fourth aspect, so these are the three differences we can say between MGRS and NCHS. The fourth difference would be that the new WHO standards depict normal early childhood growth under optimal environmental condition, on optimal environmental condition. So because of this, because it is calculated under optimal environmental condition, it can be used anywhere, be it in India, be it USA or some other places, regardless of ethnicity, socioeconomic status, and the type of field. So that is the first question with regard to the WHO growth charts. Now, next question is about what are the characteristics of WHO growth charts and how is it different between from ICDS growth chart. So let's see how the WHO growth chart is there. So we have this diagram. So here age will progress on x-axis, on the y-axis weight of the child would be there. Remember, the best method to measure the growth would be weight for age. So there are two curves. Upper curve is called upper reference curve and the lower curve is called lower reference curve. Upper reference curve is the 50th percentile of boys, while lower reference curve is third percentile of girls. So remember, this is for boys, this is for girls, this is 50th percentile, this is third percentile. So the area between these two is the road to health. At the same time, we should remember this lower reference curve is in fact 2 standard deviation lesser than the upper reference curve. ICDS also uses the same standards, but it has 3 curves. So there are 3 curves. So first curve is the this upper reference curve of this thing, then lower reference curve and -3 standard deviation. This is -2 standard deviation. So because of 3 lines, we are able to quantify the malnutrition. So as we know, it can be mild, moderate, or severe. So between first 2 lines, it is called road to health. Between these 2 lines, -2 standard deviation to -3 standard deviation, we will call that there is mild to moderate malnutrition, and below -3, this clearly means that the child is suffering from severe malnutrition. So this is with regard to these 2 standards that we are using. ICDS charts are used at Anganwadi centers. So let's move forwards. Now, having done growth charts, let's see one question can directly come is what are the uses of growth charts, because it's directly given in the part. So first use is it is used for growth monitoring. So there are 7 uses we have to remember all. So growth monitoring of a child is done through use of this growth chart. Second is it is used as a diagnostic tool. So it can identify malnutrition. So this is the normal thing. Growth monitoring, diagnostic is it can diagnose malnutrition, a problem. Third is it can be used in planning and policy making. How it can do is that a large number of growth charts can be used in order to grade the level of malnutrition in a particular community and area. So accordingly, plans and policies can be formulated. Fourth is educational tool. It can be used as an educational tool because it is visual in character, and you can teach mother that, see, this is the road to health, and you have to keep the weight of the child between these 2 lines only. So this is the utility of a growth chart. Fifth utility is that it is also a tool for action. So we have various healthcare workers which may not be well educated in order to understand the utility of these minus 11.5 less than minus severe, how to differentiate between mild, moderate, severe malnutrition. So using this visual pictography, they can easily use it as a tool in order to go for intervention in the community. Sixth one is it used in order to evaluate effectiveness of the corrective measures that have been employed. If the child goes like this, so clearly the malnutrition has been prevented. And last is tool for teaching. So through it, this we can teach that there is importance of adequate feeding should be there. So these are the various what we can say is the uses of growth chart. Seven uses are there. Now let's move on to rights of women and children. The rights of women and children. So we have to remember certain dates. So the first date would be 1948. Everyone knows it is Universal Declaration of Human Rights. Then afterwards, we had 1966. These are common dates: 1948 and 1966. 66 is International Covenant on Economic, Social, and Cultural Rights. So that is there. And there are two things. So one happened before it, which was related to child, and one happened after this. So in 1959, so Declaration of Rights of Child was there. Declaration of Rights of Child. And in 1981, we had CEDAW. CEDAW means Convention on Elimination of All Forms of Discrimination Against Women. So this is these two with regard to child, we can always start with 1959 Declaration of Rights of Child, and with respect to women, we can go for 1981 CEDAW, the Convention to Eliminate all forms of discrimination against women. Again, in the background, we can mention 1948 Universal Declaration of Human Rights and 1966 International Covenant on Economic, Social, and Cultural Rights. So these are the broad framework. With regard to India, if we go by the Constitution, in the Constitution itself, there is a mention of rights of the child and women also. So how is it mentioned? So especially with regard to the child, if we go, Article 24, it prohibits employment of children below the age of 14 in factories. So hazardous occupation is prohibited. Article 39, it is a DPSP, which says that steps should be taken by the state to prevent abuse of children of tender age. And last is Article 45, which provides for free and compulsory education until they achieve 14 years. So that's a directive principle of state policy that is used. After Constitution, let's go for policies. So first national policy on children was there in 1974. There, children were called as nation's supremely important assets. Supremely important assets. Afterwards, certain reviews have happened, and finally, what we have to remember is this National Policy of Children 2013, so the latest policy. So again, we are aware that 2009-10 Ministry of Women also launched ICPS, Integrated Child Protection Scheme. So let's first of all do 2013 National Policy for Children. So it is a long-term, sustainable, multi-sectoral, multi-integrated approach for development protection of 0 to 18 years of child age group. So survival, health, nutrition, development, education, protection, participation are the key priority areas of the policy. So next recent step we can say is POCSO Act was passed in 2012, which defines child as someone lesser than 18 years. An amendment was there, and which said that from 16 to 18 years, there would be a committee deciding whether the child has committed a heinous plan. And the latest is National Plan of Action. National Plan of Action for Children. So it was adopted in 2016. So it is based on earlier policy framework and has 4 priority areas. So first is the survival. Child survival should be there. Then health and nutrition. And third is education and development. And fourth is protection and participation. So these four components were emphasized by National Policy of Action for Children. So let's move further related to it. So what is this? We also have something called Global Strategy for Women's and Children's and Adolescents. health. So it is between 2016 to 2030. So it is aligned with sustainable development goals at the international level. So there are certain trends which we can witness in MCH care. These are: first is are right now focusing on integration of the care, right from the birth till the adolescent, so 18 years of age. Then we use risk approach. What is risk approach? Is that we identify high risk patients and we refer it to higher centers. And third is we are using manpower changes. New type of manpower are used, like professionals, field workers, and voluntary workers. So, and the fourth is that there is a focus to provide MCH care at the primary level, primary health care only. So, what are now, these are the new approaches we can see in MCH care. So, now let's see what are the indicators which can be used in order to indicate MCH status of MCH care. First indicator is maternal mortality ratio. So, so again, the indicators can be divided into maternal mortality indicators and child mortality indicators. So let's discuss the maternal mortality indicators. First is MMR, maternal mortality ratio. So before that, we should know what is maternal death. So maternal death is defined as the death of a woman while pregnant during the time of pregnancy or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy. And it should, but not from accidental or incidental causes. So that is the definition of maternal death. So we have two things: maternal mortality ratio and maternal mortality rate. So there are two different things. So in the numerator, both have number of maternal deaths in a given period. So the same thing here. But in the denominator here, we have per 1 lakh live births. Here per 1 lakh women of reproductive age group. So that is maternal mortality ratio and maternal mortality rate. So how to measure maternal mortality ratio measurement? There are various methods. First method is civil registration system. Second method is household surveys. Third is sisterhood method. And fourth is Ramos. Ramos means reproductive age mortality studies. And fifth is verbal autopsies. Finally, census is there, but it gives very delayed data after 10 years. So let's move further of our global. Let's take the global scenario. And then in global scenario, we have something called Global Strategy for Women's, Children's and Adolescents Health 2016 to 30. Global Strategy for Women's, Children's and Adolescents Health 2016 to 30. So it has a vision to have by 2030 a world in which every woman, child, and adolescent in every setting realize their rights to physical and mental health and well-being. The strategy is a roadmap for the post-2015 agenda. So it focuses on three goals. What are three goals? First is survive, thrive, and transform. STTs. Survive, thrive, and transform. So survive. So how to survive and preventable deaths. So mechanism to end preventable death is reduced global maternal mortality to less than 70 per 1 lakh live births, newborn mortality to 12 per 1,000 live births, and under 5 mortality. We have to reduce all these mortalities. Along with that, we have to reduce and the epidemics of HIV, TB, malaria, and neglected tropical disease, and non-communicable disease. Because of non-communicable disease, reduce one-third premature mortality. So this was a survivor. Fourth, thrive is to ensure health and well-being. So how to ensure health and well-being is by so that was survival. Next is thrive. So it is to ensure health and well-being. Health and well-being. Um, and all forms of malnutrition, ensure universal access to reproductive and child health services, ensure all girls and boys have access to good quality early childhood development, substantially reduce pollution related deaths, achieve universal health coverage. Last is transform. So transformation is that we have to expand enabling environment, eradicate extreme poverty, ensure that girls and boys complete free, equitable, and good equality primary and secondary education, eliminate harmful practices and all discriminations, mm, and violence against women and girls, achieve universal equitable access to safe and affordable drinking water, enable scientific research, upgrade technological capabilities, and encourage innovation, provide legal identity for all, including birth registration, enhanced with the global partnership. So this is global strategy. Now let's go to what are the maternal determinants of mortality, determinants of mortality, uh, maternal mortality in India. So this is a highly probable question. We can divide it into two aspects: social factors and medical causes. In medical causes, we can divide it into obstetric cause and the non-obstetric cause. So let's take first is social factor. There are 14 factors. First is age of the child birth, age at childbirth, when childbirth is happening. Second is parity, how many children are born. Third is that closeness of the pregnancy, how close the pregnancies are. Fourth is size of the family. Fifth is malnutrition. Sixth is poverty. Seventh is illiteracy. Eighth is ignorance and prejudice. Ninth is maternal services, lack of maternal services. Tenth is shortage of health manpower. 11th is the delivery by untrained guys. 12th is poor environmental sanitation. 13 is poor transport facilities, and 14th is social customs that hamper maternal survival. However, the medical causes can be obstetric and non-obstetric. These are 5 and 4. 5 obstetric, major obstetric causes are toxemia of pregnancy. So we can divide like HIE here too. So H means that hemorrhage would be there. So it's the maximum chances. I means infection. A means abortions. So that it would be unsafe abortion. T means toxemias of pregnancies, and O means obstructed labor. Obstructed labor. Non-obstructed causes are anemia, then malignancy, then accidents, and then associated diseases like cardiac, renal, hepatic, metabolic, and infections. So this is about maternal related indicators. So we can now move on to the indicators related to indicators. So let's do it tomorrow.